Hi, my name's Tim. I'm one of the residents at Nepean Hospital, and this is a short talk on chest x-rays. I think it's really important to be able to interpret chest x-rays because they're used so ubiquitously in the hospital and also in the outpatient setting. Feel free to email me if you guys have any questions. And all of the images in this presentation are taken from Radiopedia, which I'd highly recommend as a really good website. First, a bit of theory. Chest x-rays and all x-rays are based on the notion that different materials have different radiographic densities. And this extends all the way from metal, which obscures almost all x-rays, therefore appearing white on a film, through to bone, soft tissue, fat, and air, which transmits almost all x-rays, therefore appearing black on a film. Have a look at this chest x-ray. This is a normal chest x-ray, but I think it's very helpful to have some kind of pro forma to avoid missing things when we interpret chest x-rays. So one that I find really helpful is Doctor's ABCDE, which has been popularized by Life in the Fast Lane. So to take you through that, D stands for details, where we comment on the patient's history, their age, and the timing of the chest x-ray. RIPE is an acronym. R stands for rotation. So we check that the distance between the right clavicular head and the spinous processes is the same as the left clavicular head to the spinous process. I stands for inspiration, where a good amount of inspiration would allow you to see 8 to 10 posterior ribs and 6 to 8 anterior ribs. P stands for picture, so we make sure that the chest x-ray visualizes everything we should see. And we can comment as to whether it's a posterior to anterior, PA, chest x-ray, or AP, anterior to posterior. E stands for exposure, where in a good amount of exposure, we should just be able to see the vertebral bodies through the mediastinum. S stands for soft tissues and bones, where we comment on any overt swelling, any air where it shouldn't be, like subcutaneous emphysema. And we look to see any fractures, looking at the ribs, the clavicles, and so on. A stands for airway, where we first look at the trachea to make sure it's midline or slightly to the right is acceptable. And then we look at the carina as we trace down the trachea. B stands for breathing, so we look at the lung fields. We check the vascular markings we can see. We look for any opacification in the lung fields and the distribution of that. We can also have a look at the hilar, making sure they look normal and don't look enlarged. C stands for circulation, so we can comment on the width of the heart, and we can also see some vessels, such as the aorta here. This is the aortic notch. D stands for diaphragm. We comment on both hemidiaphragms. We can look at the costophrenic angle, where we should be able to see a sharp angle here. And it's also quite normal to see a gastric bubble. E stands for extras, so we comment on any paraphernalia, any ECG leads, any central lines, and so on. Lateral x-rays are less common than AP or PA x-rays because of the higher amount of exposure, and also often enough information can be gained from just a good PA x-ray. But lateral x-rays can be helpful for localizing the location of a specific pathology, whether it's in the anterior or posterior part of the chest. We can see all the same structures in the lateral chest x-ray, so we can see the heart here. We can see the vertebral bodies, which get darker as you go down, which is the more black sign, which is quite normal. This is the first case, a PA x-ray of a 60-year-old male who presents with acute onset shortness of breath. And before each x-ray, I'll play this timer, and please pause if you would like to interpret the x-ray before I jump in and start interpreting it. So I thought it would be useful just once to go through Doctor's ABCDE for a chest x-ray with pathology, and then in subsequent x-rays, I'll go through them much more quickly. So I've already commented on the details of the 60-year-old man who presents with shortness of breath. RIPE, R for rotation, we see that the distance between the spinous process and the clavicular heads is roughly the same. I for inspiration, we see a good amount of inspiration here. P for picture, I've commented it's a PA X-ray, and we can see the full chest. And E stands for exposure, and we can't quite see the vertebral bodies through the heart here, but that could partly be because of the opacification across the lungs. Soft tissue and bones, we don't see any fractures here. The clavicles and the ribs look okay, and we don't see any soft tissue swelling or pathology. A for airway, we look at the trachea, which is just slightly to the right, which is okay, and we can also trace down to the carina. When we get to breathing, we can comment on a lot of pathology we see here. So we see this fluffy opacification that's extending out from the center, and that's in a typical distribution of alveolar edema, and I'll touch on that a bit more in a second. We also see some prominence of upper vascular markings, which is upper lobe diversion over here. In terms of circulation, the heart is wide, more than 50% of the width of the chest. Yep. D stands for diaphragm. We see some partial obscuration of both hemidiaphragms because of this edema. We can see some blunting of the costophrenic angle, and here we can't see a gastric bubble. And there's no equipment on this chest X-ray. So this chest X-ray is fairly typical of alveolar edema, and what that's described as is the bat wing sign, where we see this fluffy opacification extending out like the wings of a bat. That's where the fluid from the pulmonary edema is caught in the alveoli. I also commented on upper lobe diversion, where you see the prominence of these pulmonary veins, and that's due to increased pressure in the pulmonary veins, which can occur in heart failure. And I also commented that the width of the heart is more than 50%, and that's abnormal and can also be associated with some heart pathology. There's blunting of the costophrenic angle, as I commented on. Okay, so in the second case, we have a PA chest X-ray of an 80-year-old male who's presenting with fatigue and shortness of breath. In this chest X-ray, we again see pulmonary edema, but in quite a different distribution and with different signs to the previous chest X-ray. So whereas the previous one was of alveolar edema, where the fluid is in the alveoli, this is more consistent with interstitial edema, where the fluid is in the interstitium. So in this chest X-ray, and I'll zoom in a second, but we can see some lines of fluid in the interstitium, which are known as curly B lines, extending out from the edge of the chest. We see some general opacification. We see some peribronchial cuffing over here. And we see some air bronchograms as well. So here I'm describing the curly B lines. So these are lines that are interstitium filled with fluid that extend from the edge of the chest, and they don't extend all the way out, all the way in, but they should reach the very edge of the chest. There's also some peribronchial cuffing. So we see a cross-section of the bronchus, which is more prominent because it's been surrounded by fluid, which is opacification. So we see what's sometimes described as a donut sign, where there's an area of translucency in the bronchus surrounded by opacification, as we see in this zoomed up image over here. There are also some air bronchograms, where the translucency of the bronchus is surrounded by fluid, and therefore you can see these demarcated areas of a dark line running through the chest X-ray. And in a zoomed in image, you can just see them over here, these air bronchograms. Okay, so in summary, in pulmonary edema, you can have multiple different signs, you can get a bat wings appearance in alveolar edema. You can also see air bronchograms, peribronchial cuffing. You can see curly B lines or septal lines. Sometimes there's thickening of the interlobular fissures, and you can still see the vascular markings. There are also some associations we've noticed. So in heart failure, sometimes you get cardiomegaly. Pleural effusion is associated with many things that also cause pulmonary edema. And upper lobe diversion can also be a feature found in heart failure. Okay, case 3. We have a 30-year-old female who presents with shortness of breath and left-sided chest pain. So hopefully you've been able to see that there's fairly substantial opacification in the left lung, and that's extending about halfway up the lung and demarcated by this curved border. And that's what you see in a large pleural effusion, where you get fluid in the pleural space that forms a bit of a curve because of the surface tension of that fluid. So in pleural effusion, you firstly will get a blunted costophrenic angle. And that's what happens when you have about 50 milliliters of fluid in the pleural space. But as we just saw, you can also get a meniscus sign in a massive pleural effusion. And this can start to form from about 200 milliliters of fluid, although the X-ray we just saw would have had a lot more than 200 mils. Okay, case 4. We have a 4-year-old who's been in a motor vehicle accident. So there are a number of features worth commenting on here. The first being this flat line, which, unlike in the curved line of the meniscus sign in a massive pleural effusion, this line is flat, which suggests that we have, as well as fluid in the pleural space, we also have air in a hydropneumothorax. Now, given that the history is of trauma, we have to expect that the fluid is blood. So we're looking at a hemopneumothorax. And this is the air above the fluid in the pneumothorax, where we see that the vascular markings of the collapsed lung don't extend all the way to the border of the chest. Instead, we have this area of translucency with no vascular markings of a pneumothorax. And we also have, in this chest X-ray, pneumomediastinum, where we see in the mediastinum various anatomical structures being outlined by air, such as this aortic knuckle. We see some lines of air running through the mediastinum on both sides, the right and the left. So there's been a trauma, and we've got to be looking for fractures as well. But in this chest X-ray, we don't see any fractures. And in young people, it's much less likely to have fractures because instead you'll have bones bending rather than breaking. But that still allows the lung and soft tissue structures to be damaged. So in summary, in hydropneumothorax, you see this flat line, unlike a curved line in the meniscus sign. And when you have a history of trauma, you've got to be looking for various associations, including fractures, pulmonary contusions, pneumomediastinum, air in the mediastinum, or pneumoperitoneum, air in the abdominal cavity. So this is case 5, a 35-year-old male who presents with a cough and a fever. So the area of pathology in this chest X-ray is a well-demarcated area of consolidation on the right over here. And given the history of cough and a fever, we've got to be quite suspicious of pneumonia. Now, when we contrast pneumonia to pulmonary edema, pus and fluid have similar radiographic densities. So we can't really differentiate these two pathologies based on the radiographic density, but instead we've got to be looking for the distribution and, of course, the history. So in this chest X-ray, we have a well-demarcated consolidation, and this is going to be consistent with lobar pneumonia. It's also worth commenting that you can see some air bronchograms, like you can also in pulmonary edema, and you can see them running through here. We can comment on the silhouette sign as well, where we get the loss of the right cardiac border. And in general, we can notice that when we get an interface between two materials in an X-ray, then if those two materials are the same radiographic density, we will not see a border on that X-ray. So because the heart, the diaphragm and and fluid or pus have similar radiographic density, when you have structures that are abutting, then the lung is filled with the pus or the fluid, then you lose that border. So when you have consolidation or pulmonary edema in the right middle lobe, because that's abutting the heart, you will lose the right cardiac border. And similarly, we've seen in previous X-rays where you have lower lobe edema, or equally if it was consolidation in pneumonia, you lose the hemidiaphragms. Case 6, we have a 20-year-old male who presents with 4 days of febrile illness. So again, the history is suspicious of pneumonia, but in this chest X-ray, there's quite a different appearance, where instead of a well-localized lobar consolidation, you see this patchy opacification throughout the lung. And this is also a possibility in pneumonia, but the radiographic description is different. So this would be a bronchopneumonia, where the immune system hasn't localized this to a particular lobe, but instead it's spread more throughout the lung and just within certain lobules. Case 7, we have a 50-year-old male who presents with a fever, respiratory distress, abdominal pain, and gastroenteritis. So this chest X-ray is another example of pneumonia, but yet again with quite a different chest X-ray appearance. So this is a bit unusual for pneumonia because you see this reticular pattern where you see this network of lines, which is mainly on the left, but you also see in the right lung. Now, with any opacification, you need to be suspicious of pulmonary edema, but here you don't have the features of pulmonary edema like curly B lines and there's no associated blunting of the costophrenic angle or any other signs of pulmonary edema. You've also got to be suspicious in a reticular pattern of interstitial lung disease, but this is mainly affecting one side. And given the history, is more suspicious of a pneumonia. So we've looked at different types of pneumonia, and there can be quite different radiographic descriptions of pneumonia. But the two main types are lobar pneumonia and bronchopneumonia. So in lobar pneumonia, we see localized consolidation to one or more lobes, and that's usually in response to a bacterial pathology. And in pneumonia, you see well-localized pacification, and we didn't see this in the previous chest X-ray, but you can get the opacification can be demarcated by the fissures of the lungs. We also see air bronchograms, and we can note the silhouette sign where the abutting demarcating borders are obliterated, and that will help you localize the area of the pathology. We also saw an example of bronchopneumonia, where you get a patchy consolidation to the lobules, which is also usually bacterial pathology. But there are many other descriptions of pneumonia. We looked at atypical pneumonia, and there are other types like cavitating pneumonia. Here we have a PA film. It's of a 25-year-old male who presents with a dry cough and low-grade fever, with 5 kilograms of weight loss over the past 2 months. So the pathology in this chest X-ray is a lesion, which you can see over here. And it's a unique lesion because it's not a single area of opacification, but there's some translucency inside. So you would describe this as a cavitating lesion where there's gas within the lesion. Now this can be caused most commonly by an infective process, such as TB, and 60% of cavitating lesions would be infectious. But it can also be caused by malignancy, and can also be caused by autoimmune processes or even pulmonary infarcts. In case 9, we have a PA film of a 35-year-old male who presents with chest pain. So this might be a little bit difficult to see on a computer screen, but you might be able to see that there is this line that demarcates the vascular markings that are coming up from the lung. But at the very edge of the chest, you don't see these vascular markings continue, and instead there's more translucency than there should be. So this is classical of pneumothorax. So it's an apical pneumothorax we can see here. Now, this is the same patient, but we've asked them to expire. So this is an expiratory chest X-ray. And this causes a constriction of the lung with more obvious vascular markings and probably helps you to see the demarcating line between the translucency and the normal and the collapsed lung. So that can be helpful to be able to diagnose a pneumothorax. And also it can be helpful to flip the window to invert the colors. That can sometimes help it be detected. Finally, we have the last case, a 60-year-old female who presents with acute on chronic shortness of breath. So in this film, we see a pacification extending across both lungs, and we would describe this as a reticular pattern with these networks of lines going across the lungs. And we also notice that although usually we would want an inspiratory X-ray, this is very poor inspiration. And here we can actually only see 4 anterior ribs, where it would be normal to have 6 to 8 anterior ribs and a good amount of inspiration. So both the reticular pattern of a pacification and the poor inspiration is suspicious of interstitial lung disease. Okay, so that's the end of the presentation. I hope you enjoyed it.